between this and basic life support? That's the usual query that I get from most doctors because we're doing a lot of things that are same. We are still doing CPR, we are still taking care of the airway of the patient, breathing, circulation. So isn't everything same? Yeah, it is. But there's a difference. The fundamental difference is that you are here making a differential diagnosis in a patient, that is ABCD. The D stands for differential diagnosis that is being done by the doctor here to identify why did the patient become pulseless and BPless. It could be ventricular tachycardia, broad complex QRS, where the heart is beating very fast, so it's not getting time to get filled with blood, so input and output both are falling. It could be asystole, for which the treatment is totally different from that of ventricular tachycardia, or a patient could be having a tension pneumothorax, which is compressing on the SVC, IVC of the patient, reducing the venous return, so the heart is literally beating empty. You can understand an empty heart will not be able to generate any pulse. Pulseless electrical activity could be due to conditions ranging from dangerous hypovolemia, where there is fluid loss from the body or fluid shifts in the body, or it could be tension pneumothorax, which is compressing the superior or the inferior vena cava, compromising the venous return of the patient. So in advanced cardiac life support, you make a differential diagnosis and then treat the patient accordingly. In basic life support, your objective is just to maintain brain perfusion by giving chest compressions to the patient, but here you are trying to do something beyond routine chest compressions also, that is to identify the cause and treat it. Aiding you in the very first step here is a defibrillator. When I say that the usual query from most doctors is that were you not using a AED or automated external defibrillator even in basic life support, so what's the difference? The difference is that this is automated external defibrillator. When you put it on the chest of the patient, it decides whether the shock is to be given or not given. So the AED will give out a command. It will come out with a talking software in it, will say the word shockable rhythm detected. So the decision making was done by the machine. Whereas in case of ACLS, the defibrillator will tell you a rhythm and the decision making will be done by the doctor. So I highlight this. In basic life support, you are giving CPR to the patient, like the person collapsed at the airport, one of the persons went to get the AED machine, you are the one who is giving CPR. The moment the AED machine will come, you have to deploy the paddles on the chest. Now it will read the rhythm and say shockable rhythm detected or not detected. If not detected, you continue with CPR. On the other hand, if it says shockable rhythm detected, stay clear, then you have to wait for a few seconds and the machine will deliver a DC shock to the patient. Please appreciate automated external defibrillator decision making is that of the machine, whereas in case of ACLS, the decision making is done by the doctor. So that's one of the fundamental differences here. Like for example, I can say asystole is a non-shockable rhythm. Ventricular tachycardia is a shockable rhythm. So the decision making was done by the physician. Another highlight that I can say, especially for the airway, is secured. You would go in for advanced airway here, like you will intubate the patient or you can use a laryngeal mask airway. In most of the cases in our hospitals, we intubate the patient. Now, once the advanced airway has been secured in the patient, then you will not follow the 30:2 rule that was taught to you initially. Now you will be giving one breath every 6 seconds. I repeat my statement, the 30:2 is not to be followed anymore. Like one guy is giving 30 chest compressions, fine. But if you are the one on the ambu bag, you have to press the ambu bag once every 6 seconds. So one breath every 6 seconds will translate into total of about 10 breaths in 1 minute. Another difference that I want to highlight before you is the difference between the term defibrillation versus cardioversion. A common query from a lot of my students is that after all, sometimes you say defibrillation, sometimes you say cardioversion. After all, you are still giving DC shock to the patient. So what is the difference? The difference is that when it comes to the term cardioversion, you are delivering the impulse with respect to the peak of the R wave. So cardioversion means synchronized DC shock. That synchronized DC shock means that the impulse is fired at the peak of the R wave. Why do we do it at the peak of the R wave? Mainly because that is the time when the heart is contracting abnormally. So when I will give this shock, it will make the heart electrically silent for a while. It will relax. It will get filled with blood properly, and now when it will contract the normal sinus rhythm, the SA node will take over the activity. So next time when it will contract, the contractions will be normal and there would be a normal cardiac output that will ensure brain circulation or return of spontaneous circulation, as we say. So cardioversion simply means that it is a synchronized DC shock with the peak of the R wave. I highlight the terms here. One is defibrillation, which is irrespective of the phase of the cardiac cycle, and second is cardioversion, which is done with respect to the peak of the R wave. Cardioversion is what we do for arrhythmias like paroxysmal supraventricular tachycardia or patients of atrial fibrillation if they require it, atrial flutter if they require it. On the other hand, defibrillation would be done for following situations. That would be ventricular fibrillation as shown on the display and a patient of pulseless ventricular tachycardia. Here there is no synchronization with the ECG. It's random irrespective of the phase of the ECG that has been delivered.